It looks like we lost Tammy. Stand by just a moment, please.
Hi, good afternoon, everybody. Thank y'all so much. We apologize for our technical difficulties. So we're here for a very important topic. It might be one that might be a little bit like people don't want to talk about it. I'm sure our physicians who have to talk with their patients about things related to colon might not be as good. I know in my friends and family, when we're talking about it, it might be a little bit uncomfortable, but the important thing to know is that it is important. It is Colorectal Cancer Awareness Month. And I'm proud to say that we're here with 3 of our experts from Prisma Health, because our goal here at Prisma Health is to make sure you have the information that you need to make informed healthcare decisions. We want you to be well. And in order to be well, working with our experts, we want to give you the right information to do so. So I'm happy to say we have Dr. Anthony Baglio here with us. He's a family medicine physician at Family Internal Medicine in Five Forks. And then we have Dr. Cedrek McFadden, the colorectal surgeon at ColoRectal-Centennial, and Dr. Williams Perkins, who's a gastroenterologist at Gastroenterology and Hepatology in Sumter. So thank them for coming. So now that we're here and we're talking about this important topic, you might know that the American Cancer Society rates colorectal cancer as the 3rd leading cause of death in the United States. And so when you're thinking about that, you're like, really? Some people might not be familiar with that. So what we're going to do is have our panel of experts answer a bunch of questions that you might need to know. The other thing I want you to do is, if you have a question that you want answered right now, you could put it in the chat here on this Facebook Live, and we'll try to answer it for you either now or later. So I'm going to start with a general question, and we're going to highlight Dr. Perkins, and Dr. Perkins is going to give us answer to this question. Dr. Perkins, thank you for joining us.
You're welcome.
All right, so tell us in general, when people say colorectal cancer, like what is colorectal cancer?
Colorectal cancer is a type of cancer that arises from the lining of the colon and rectum, also known as the large intestine. It generally starts out as a small growth called a polyp, and over time it develops into a tumor or mass. And then if still undetected or untreated, it could erode into the wall of the colon and get into the bloodstream, and then it can spread to other organs in the body, which unfortunately, if that happens, the chances of cure are very low. So the good news is that it's very typically slow growing compared to other cancers. And we have a window of opportunity to go and remove the little growths or polyps before they get a chance to turn into cancer or develop into a tumor. There's other types of cancers that can occur in the colon and rectum, even like under the surface of the lining, but those are generally not thought to be colorectal cancer. You know, in the strict sense, they behave differently and are really treated differently.
Well, thank you. With that, we're going to say, okay, we kind of know what it is. Now we're going to ask Dr. Baglio to kind of talk to us about when should you be screened. Dr. Baglio.
Yeah, absolutely. So recently there's been a guideline update from the major body called the United States Preventive Service Task Force on when basically we get screened the most, when we get screened for colorectal cancer. Most people now, we recommend getting screened starting at age 45 to 75. And then as far as, I think also the American College of Gastroenterology also agrees starting at age 45. yeah, we start from 45 to 75, and then for individuals that are 76 to 85, it's more of an individual basis. For folks that have different other gastrointestinal diseases, specifically inflammatory bowel disease like Crohn's disease or ulcerative colitis, sometimes they have different screenings in the general population. So sometimes they'll be screened sometimes 8 to 10 years after diagnosis, or sometimes we'll refer to our gastroenterologist friends. For folks that have a relative, first degree relative, like a parent, sibling, or child with colorectal cancer, sometimes we'll end up screening at age 40 or 10 years earlier than the relative was diagnosed with cancer. And as far as basic risk factors for colorectal cancer that people should be aware of, generally people who are not leading like an active lifestyle, so we call like a sedentary lifestyle, people eating low fiber diets, high in fat, processed meat or red meat, people who are smoking, drinking alcohol, and then also people, like I say, who have that inflammatory bowel disease like Crohn's disease or ulcerative colitis, and people with genetic conditions, sometimes like familial adenosis polyposis. But for this, the average person shouldn't really start until age 45 otherwise.
We have seen some literature, and I think the other docs can add to this too, that we are seeing colorectal cancer earlier, younger, which is why I think the governing body went down to 45. And as you said, I guess if you have a family history or other things, that you might even be screened earlier than that. So would you think that one part of that message is really like knowing your body and being careful and knowing when things don't go quite right?
Yeah, I think so. Yeah, I mean, I think the big thing is, I think, with the screening, it's a lot of times that's a primary prevention thing, meaning otherwise we're looking in someone who otherwise had no symptoms. Now, if someone, notices something like they have rectal bleeding and they get checked and they don't have hemorrhoids or some sort of anal fissure or anything, then they probably should be evaluated sooner because they have another actual reason.
Yeah, okay. With that, we're going to go to Dr. McFadden. Dr. McFadden, so we know you've done a lot, talked a lot about this, but we want to talk about how this impacts African-American, Black and Brown communities, specifically colorectal cancer.
Yeah, so thank you for having me and for paying attention to a very important topic. We know that colorectal cancer affects different communities differently. African Americans have the highest incidence and mortality rates. African Americans have a 40% higher death rate and 20% higher incidence of colorectal cancer. There are several reasons why this is thought to be the case. Some of it's related to genetics, but there's growing literature and recognition of the importance of the factors which we would call the social determinants of health. It's relating the ability of people to get the quality health care that then impacts their outcomes. It relates to their ability to get to the doctor, the ability to be able to pay for their health care. It also relates for all the other factors in their environment, in their social economic groups that then influence their outcomes as well. It also comes into some discussion regarding the impact of systemic racism that can be present, or biases that can be present in both the patient as well as the treating physician. And so there's been a lot of energy around identifying so that we not only acknowledge, but we also address and move beyond so that we can give proper care as it so rightly should be given.
Good, thank you. Thank you, Dr. McFadden. We're gonna go to Dr. Perkins.
Yes.
Dr. Perkins, so your question as a follow-up to that is, what are some of the signs and symptoms of colorectal cancer?
Well, one of the reasons why screening makes so much difference is that often there are no signs or symptoms of colorectal cancer until it's much, advanced. But if I had to think about all the cases that I've diagnosed, I would say the two most common things are probably rectal bleeding and unexplained low blood counts or anemia, particularly in someone who has never been screened or has a family history of colon cancer.
Good deal. Thank you. So I guess when people say, there's no signs or symptoms, and so I shouldn't worry about it, what would you say to that question?
I would say take a look at all the scientific studies that have been done that have shown clear saving lives actually through getting screened. And it's just taking a big risk if you don't get screened. And of all the types of cancers out there, I'm not aware of any other cancer that has such good data to support screening and clearly saving lives and preventing cancer. So,
thank you. Go ahead.
I'd probably
hold on.
add.
Let me do that. Go ahead.
I'd probably add to that really good point that, I often tell patients that we don't want people to wait for symptoms, because often if we're waiting for symptoms, we have disease that may be a little more advanced. And so we want people to be screened, right, at the age of 45, or if there's that family history, a family history of colorectal cancers or polyps, that you're going to begin screening. And regardless of your age, if you have symptoms, you need to be tested. And that's really important for people to remember.
Good deal. All right, we're going to go to Dr. Baglio. So Dr. Baglio, what is the most effective way to screen for colorectal cancer?
So the most effective in the sense that it's the most comprehensive and best test is going to be the colonoscopy, because it's really it's a test that they're able to actually visualize the inside of the colon, see if there's any growths or polyps, obtain those tissue samples and look under a microscope and see, is this something that is benign or harmless, or is this something that's cancerous? So that's the most effective, I guess the gold standard test is the colonoscopy. Having said that, there are a number of other tests out there now.
And what do we think about the other tests? I mean, how do they what are they appropriate in some settings? Absolutely.
So, the other philosophy too is the best test is a test that gets performed. So if someone, although colonoscopy is the gold standard, there are other great tests out there, like you might have heard of the Cologuard test, which is fit DNA test, where they're basically testing for DNA mutations in the stool. And that test has a lot of great evidence behind it, as far as if someone has a negative test, it's very, very predictive of a negative value. But having said that, it does have some limitations where there can be false negatives and some people could slip through the cracks. However, those are very, very rare. But they're all also, there's other screenings too. There's the guaiac stool test, where we basically test the stool for blood. That's another test that could occur annually. And then now there's also CT colonography, which is it's another test, but not really maybe the best test.
Good deal. Thank you. We're gonna go to Dr. McFadden. So Dr. McFadden, I've had a colonoscopy before. People are like, what? This doesn't sound too fun. So talk to us about what the options are, how you like going into a colonoscopy, some of the things you can do to prep, and kind of that whole experience of what it's like. I know you had this conversation with a lot of people before, so tell me what you think about it.
Right. I mean, I don't know too many people that are running to do a colonoscopy because they like the prep. It's just not what people enjoy doing. But, it is very important to do a great prep, because you want to do one prep one time. You don't want to be repeating it because the prep wasn't adequate. And that preparation is very different than perhaps it used to be. Most of us are employing smaller volume-based preps. We're no longer generally requiring you to do 3 or 4 liters of a prep, as opposed to a much smaller volume that we're splitting into 2 doses. We also have changed the way most of us administer the sedation. Most of us use IV propofol or Diprivan. It is a great nap. Most people will say it's probably one of the best naps you'll ever have. And most people wake up saying, wait, that was too quick. I want more of that nap. So it's a great procedure itself that day. As you're preparing for it, you know, in our office and in several others that I'm aware of, you know, we no longer require that you have a complete fast the day before. We allow you to have some lower residue type food items as you're prepping the morning before your colonoscopy. So we allow you to have white rice, you know, without any oils or butter. Some of the research shows it may improve the prep quality. It also improves your energy and makes you not so much of a curmudgeon as you're preparing for the colonoscopy. And there are other things you can have that people sometimes forget are allowed, such as black coffee without, you know, cream, of course. You could also have things such as hard candies. You can have gummies. You can have a root beer. And your prep doesn't have to mean your soup has to be, you know, something you open from the grocery store. I've said before, but I advise people, you know, if you have a favorite restaurant and you like soup that they make, ask them to prepare you a prep or a soup that you can do the day before your colonoscopy. So there are ways that you can make it as exciting as you can take it. But at the bottom line, you know, you still need to do a quality prep so you're not having to repeat it because the prep wasn't appropriate or sufficient for the colonoscopy.
What do you think? We've heard a lot of people who are just, when they talk about colonoscopy, they're afraid of the procedure. I mean, I know lots of friends of mine who've been like, I don't know about it. I mean, and these are people who do have access. So what would you say when they're using that as a reason or a reason why they're not having a colonoscopy?
Yeah, I mean, I think there's a general fear when people come to the doctor of what you'll find out, right? What's going on now that you're going to tell me is going on that may change my life, right? There's the fear of the unknown. But ultimately, I say, you know, let's have more of the stance of look what we can take care of when we find it. And that, you know, if found early, colorectal cancer can have survivals greater than 90%. And so that's the piece that I want to arm patients with. And empower them with knowing that you have the power to change your outcome by finding something when it's early, so that you can continue to be around for your family and for your friends. And often it's just to say, you know, if someone's on the fence, I say, well, come talk to me. Let's have a conversation about a colonoscopy. And that way we can hear everything that you're afraid of, hear what those concerns are, maybe address and, you know, get rid of some of those fears that are false, and that we can hopefully alleviate them so that you can have the procedure that we know that you really need to have.
Thank you. We're going to go to Dr. Perkins. Dr. Perkins, there are some reasons why people are not being screened, and some of them don't have to do with their fear of the procedure. Some of them, there are other things. You know, you have to have transportation, you have to have somebody accompany you. Insurance requires certain kind of preps, don't you like? So what do you say about some of the reasons why people are not being screened?
Oh, well, I've heard several reasons. I think a lot of what I hear often is fear of the procedure, and a lot more often than not, it's actually fear of being put to sleep. And you know, to echo Dr. McFadden's point, the sedation aspect has really improved, I would say, in the last 10, 15 years, with the use of anesthesia providers and propofol being more widely used. So I would say confidently say that a colonoscopy is a safe procedure. It's a very low risk procedure, and even the sedation aspect is low risk and is safe. I mean, certainly medical comorbidities might put one at increased risk, and that's, you know, a discussion to have. But we're talking about screening, you know, a 45 age to 50, you know, age working individual usually. And I think the procedure is safe. And one important point, I think this whole discussion, we really should walk away knowing that colorectal cancer is preventable. And I really hate to diagnose a new case knowing that it is preventable. And if we could have just done this or that differently, we would have not had this outcome. So yeah, transportation, I think most people, you know, we live in a very resource rich country. And I think if you knew that it could save your life, you might, you know, could find someone to take you home from the procedure. The other concern, you know, would be the procedure itself, which again is very safe, but you have to make sure, you know, you're going to someone who's qualified to do it and is trained appropriately to do it. I hear a lot of people talking about how they knew somebody that had a colonoscopy and there was a bad outcome, and you know, certainly that leaves an impression on someone. But you know, adverse outcomes and events after colonoscopy from an expert who's trained in it is very, very rare. And I think if you just look at the overall benefit and how many lives we're saving, how many cancers are preventing, it's kind of a no-brainer.
Yeah. I'm going to go to Dr. McFadden, but it always makes me think that the I know somebody theory, that nobody really knows who the person is. You know, like it's not, at the Perkins, it's like not a real person. It's like, I know somebody, and then everybody's like, well, who is it? And nobody seems to know who that person is. So anyway, so Dr. McFadden, okay, so we go in there, you have a colonoscopy or one of the other screening, you know, you have that, and they say you have colon cancer. How is that treated?
Well, the treatment really depends on the stage of the cancer itself. So once we find that there is a cancer present, it's biopsied, of course, and we have our pathologists. They've looked at it under the microscope and they say, yes, this is a colon cancer. Well, the next thing we're going to do is to have a conversation about getting some pictures. So we'll get some x-rays. Those x-rays may include CT scans. Depending on where the cancer is located, if it's in the rectum, it may include an MRI as well. There'll be some blood work that will probably be retrieved as well. And that staging is going to help us determine the best course of action. This is not a cancer that you want to be unintentional, right? We want to be very clear. We want to be very protocol driven. We want to be evidence-based. We don't want to forget that we didn't do something. So all of our patients, for instance, with rectal cancer, we present at a rectal MDC conference where we have not only colorectal surgeons there, we have the pathologist present, we have the radiologist, we have our oncology colleagues, we have our radiation oncologist, and we even have our nursing partners there. So there's a whole lot of conversation that happens about you before perhaps you even see some of the people you may meet, because we want to make sure we're doing all the right things. And this is probably a good time to plug the benefit of consideration for clinical trials, because in some of these conversations, we recognize that patients may be appropriate for certain trials that then will come into play as we go through your treatment options. And that's what we do have at Prisma Health. We have access to plenty of the clinical trials that you're going to see at some of the larger institutions. We have access to them right here as well. So we do that routinely every week with our MDC conference for rectal cancer. But once we've established the stage of that cancer, it may involve a combination of surgery, chemotherapy, and radiation. And depending on the type of cancer you have, particularly rectal cancer, those are going to be patients, if staged appropriately, they would receive radiation. Colon cancer is primarily treated with surgery and or chemotherapy, depending on the stage. So if we have lymph nodes that are positive, you're going to be offered some chemotherapy. If it's just limited to the colon with no other areas involved, it may just be a surgical procedure. And surgery does not mean that you have to have a colostomy. Often that's one of the biggest concerns from people. They say, well, I don't want to have surgery because I don't want the bag. My grandmother had the bag and I don't want to deal with the bag. Well, fortunately, if we can get to your cancer sooner before it's an emergency and the cancer is in a pretty good location, you may not need the ostomy or the stool bag. And so that's part of having that conversation with the doctor. That's why we want to see you, we want to talk about all the things that you're concerned about, because in many cases, what you're concerned about may not be your reality. And that's why we need to see you. But that's the general consensus of kind of how these cancers are treated. A combination of surgery and or chemotherapy and or radiation, but it all depends on the stage of the cancer that we would get once we get the diagnosis made.
Good deal. I'm going to go back to Dr. Perkins for a second. Dr. Perkins, we didn't talk about the fact that sometimes people, when they have their colonoscopy, there will be polyps there present at the actual time, and what happens in that scenario. So can you talk through that as a gastroenterologist?
Sure. I mean, that's the whole point of doing a colonoscopy is removing the polyps. And so, you know, as one considers the modalities of screening, colonoscopy is the only one that clearly prevents colon cancer because it removes the polyps before they get a chance to turn into cancer, whereas the other ones are kind of more geared towards detecting a tumor if it's present. So yeah, we go in during the exam. It's a flexible tube with a camera and a light and has a working channel for devices that we use to remove the tissue. Even for removing very large polyps, though, it's still safe because we're working just on the mucosa surface. And we do the exam, and if you have any polyps, we remove them, send them to pathology. An expert pathologist will look at it under the microscope and, you know, kind of determine what type of polyp it is. And certain types of polyps have different risk profiles, and that helps one determine when you might need to come back for your next colonoscopy. And also one important point is if you have a history of polyps, you really shouldn't do the other screening modalities anymore. You really should be entered into a surveillance program and talk to your doctor about, you know, when am I supposed to come back for my next one? But yeah, detection of polyps is the whole point of the procedure. And then, you know, that really kind of goes back to the quality of the bowel preparation and the quality of the exam. So you want a high quality exam. And with that, if you have an average risk screening, if you're an average risk individual and have a high quality exam that's negative, you really don't need any other screening for 10 years. That's kind of the guidelines have shown that. So.
Yeah. Well, I wanted to add that because I've had several people, and that have had some polyps, have them removed and never had another problem ever. You know, they just, happened, and they've gone back for their colonoscopy when they're supposed to, and then they didn't need any additional help. So I think people should realize that that's the reason why we're doing the colonoscopy.
Yeah, that's right. And it really, as we learn more about what causes colorectal cancer, we might be able to have more predictive models and be able to better advise people, because it seems to be caused by genetic mutations, some that you get from your parents that are inherited, and some that accumulate throughout your life. And some individuals, they may just have a couple polyps throughout life and that's it. Whereas some just seem to have a lot of polyps, and you may remove them all, come back in 3 years, and there's a lot more that have occurred in that short interval. So individuals are different based on environmental factors and genetics. And but that said, I think that we have thousands and thousands and thousands of data. Patients that really guide our decisions on interval screening and when you need to come back. That it's really, really robust data to make good decisions. And I think you can feel confident following the guidelines in terms of, when you should come back if you have a history of polyps.
Good, thank you. I'm going to go to Dr. Baglio.
Mhm.
All right, Dr. Baglio. So they're saying, good diet is important and that fiber-rich diet is important. So why is it important? And what would be some examples that you would tell people who are trying to be protective by having a high fiber diet?
Yeah, so fiber is really important because fiber influences your gut microbiome. So you've probably seen in the news, and it's been all the rage lately, your gut biome, your microbiome. So the fiber rich foods actually promote help basically your good gut bacteria metabolize the fiber into short chain fatty acids or butyrate, which can actually have anti-tumor properties. So this can actually be helpful as far as controlling some of the modifiable risk factors for colorectal cancer. Having diets that are higher in animal protein, processed meat, high sugar, alcohol, they can be more damaging and create more toxic metabolites to basically the gut and damage the DNA, which could further potentially cause colorectal cancer. Now, having said that, there are like we've discussed earlier, some of the some of these risk factors are non-modifiable, like the genetic factors, but folks can modify their diet, and that's why we do recommend having at least, I'd say 30 grams of fiber, and some experts even ask for 50 grams of fiber per day to try to reduce the risk of colorectal cancer. So foods that are high in fiber include fruits, vegetables, legumes. So think about bananas, apples, strawberries, blueberries, blackberries, black beans, lentils, broccoli, spinach, kale, all these things. So really, you can't go wrong with having a plant-based diet and trying to reduce your processed meats, your red meats, your alcohol consumption, quitting smoking. All these things really help prevent or at least reduce the risk of colorectal cancer.
All right, good deal. Thank you. We're going to go to Dr. Perkins. Okay, Dr. Perkins, this is kind of a colon question, but not a colon cancer question, because we see this on the TV all the time about people doing colon cleansing. And whether that is something that people should be doing. Is that helpful? Is it harmful?
Well, a lot of what I hear about colon cleansings appears to be like an enema. I suppose there are like purges that people do. I think it would help with weight loss because you're clearing out your colon. So maybe in that regard, but I don't really think it would have any overall impact on the health of the colon itself in terms of colon cancer, risk of inflammatory bowel disease, or any of the other disorders in the colon. And I think it could be harmful depending on what type of purge that you might do. Especially if it's not something that's FDA approved or a commonly used thing that's been studied in humans before. But I'm not aware of any medical benefit for doing those.
Yeah, I think I saw it in some weight loss things too. So I think that is all the questions that we had. Did anybody? So I'm going to go to each of you and let you, since you're up, Dr. Perkins, and you're talking, I'll let you, any final thoughts that you want to give to the community out there in reference to colorectal cancer?
Yeah, I think one last thing I would probably say is, just as new modalities of screening come online, and even the ones we have available now, there may be probably the next thing I think we'll see is a blood test that will help, determine one's risk for colon cancer or whether they may have a precancerous growth. But all these things, as one is evaluating, which one should I do? It's often beneficial to check your insurance policy, because a lot of health insurance policies have a provision for colon cancer screening, and they generally would cover a screening for the patient. The reason why they do that is because they know that it will save lives and prevent cancer and ultimately, be cost effective. So as you're kind of thinking about which modality to do for screening, kind of look at your policy and think about that, because as I said, a lot of policies will cover one type of screening. So one thing that I've kind of seen that just to kind of be aware of is, say if you do a Cologuard or a FIT test or something and it comes back positive, then of course you need to have a colonoscopy. But then you might have to pay out of pocket for that colonoscopy, depending on how your policy is structured and how your deductible is. And so, especially if you have a high deductible plan, you could end up coming out of pocket pretty significantly. Whereas if you would have just done your colonoscopy from the start, you would have paid nothing. So, it's just these little things and just to be aware of, to maybe look at the policy and think about that before you just kind of jump and do a test, because it would be beneficial for you. But again, like Dr. Baglio's point, any kind of screening is better than no screening at all.
Right. With that, I go to Dr. Baglio. Dr. Baglio, final thoughts, colorectal cancer awareness month. What would you say to the community?
Yeah, my final thoughts are, try to take ownership of your colorectal screening. And I mean, I recommend reach out to your primary care physician. I mean, colorectal cancer is a preventable cancer, and talk to your primary care physician about colonoscopy. I think, as far as modifiable risk factors, make sure that you're looking at your lifestyle and seeing if there are things that you can try to work on, whether it's quitting smoking, whether it's reducing your alcohol intake, whether it's trying to incorporate more fiber into your diet, trying to cut back on red meats, processed meats, and try to live a healthier lifestyle with physical activity, losing weight, and trying to just lead a healthier lifestyle. You can really you can reduce some of the risk for colorectal cancer. And that would be my message for anyone who's wondering what they can do.
All right, Dr. McFadden, final thoughts.
So I think one of the big pieces of advice I would give anyone is to really pay attention for symptoms. If you have symptoms present, don't ignore them. Some people have a 3-day rule, some people have a 2-week rule, but if you're treating hemorrhoids or what you think are hemorrhoids that are bleeding and you're still having the same problem, then you got to check and make sure it's not something else. And so don't ignore symptoms. We've seen colorectal cancer diagnosed in young ladies around their time of pregnancy, and they've been often either disregarded or they themselves ignored it because, oh yeah, you're pregnant, you had some hemorrhoids, it's just that. Well, if you've treated the problem and the problem is still there, make sure that is indeed the problem. And so be tested. And ultimately, the last word would be to not be afraid to ask for a second opinion. If you are talking with your doctor and they perhaps don't think you need to have a colonoscopy, or they won't, God forbid, offer you a colonoscopy, find a new doctor. We got a bunch of them around here. So one of us will take care of you, but ultimately take ownership, as Dr. Perkins said, of your health. And that includes not being afraid to ask for a second opinion. We want you to interact with us. We want you to ask questions. And there are times in which we're going to recommend a second opinion. So if your treatment plans don't seem appropriate for what you think you need, don't be afraid to speak up and ask for more information or another opinion.
Thank you. Thank you to everybody. Thank you to our experts. We are excited to have a wealth of resources at Prisma Health. I think Dr. McFadden said it well. We have the resources to help you. So if you need gastro, if you need family medicine, if you need a colorectal surgeon, if you need an oncologist, we're happy to be there to serve you. We would prefer not to see you in some of those scenarios, but we'll be there to care for you if we need to. So thank you for joining us today for the Facebook Live for Colorectal Cancer Awareness Month. If there are questions that we didn't answer and you'd like answered, please put them in the chat and we'll try to get an answer later. We thank you to our physicians for joining us, Dr. Baglio, Dr. McFadden, and Dr. Perkins for giving their time to also give important information to the community. So thank you, and everybody have a great day.